Okay, suggested approach to hematological examination. So initially all same, wash your hands and introduce yourself. General, always comment on the growth, whether the child looks ill or well. Whatever we know, I will be going fast. We will not spend time on the things what we know, okay? Any important things only will be concentrated. So we will comment on the growth, whether the child looks ill or well, and comment on the ethnicity, particularly if thinking of thalassemia, hereditary spherocytosis, and sickle cell. Okay, always observe also the ethnicity of the child. It will give you a clue whether this is thalassemia or hereditary spherocytosis or sickle cell disease, as this is highly relevant, and comment on parents' ethnicity as well if you think it is appropriate. Then you will check for pallor, jaundice as usual. Remember that hemochromatosis will lead to bronzing. Okay. So this you should keep in mind, but normally you will check pallor and jaundice. Then note the dysmorphic features and inspect upper limbs. As TAR syndrome has thrombocytopenia and absent radius, okay? And Fanconi's syndrome are associated with upper limb abnormalities. So when you also in any hematology case, along with the dysmorphic features, you will keep in mind to inspect upper limb, because in TAR syndrome, that is thrombocytopenia and absent radius, and also in Fanconi's anemia, they are associated with upper limb abnormalities. Okay, so always.
This is Dr. Noor, this is Fanconi anemia. You rightly said this is not Fanconi syndrome. This is mistake in the book.
Yeah, I did not see this. Fanconi, I read, then I said Fanconi anemia. Okay.
Yeah, yeah.
Okay, TAR and Fanconi's, you have to concentrate on the upper limb abnormalities. So there may be obvious bruising, petechiae, purpura. This also you have to keep in mind, because he said thrombocytopenia here. So related to that, there may be petechiae, purpura, or bruising. Next is hands and arms. This was general examination. Routine, what we do, the same thing. Along with that, in this you have to comment on some dysmorphic features. The facial features are described down. We will discuss it. Along with that, comment on the upper limb if you see any abnormalities. This is what he's telling, particularly for TAR and Fanconi's anemia. Next, for hands, obviously, as I said, clubbing gives you a broad differential diagnosis, like whether the child has clubbing or does not has clubbing. So it is very important in this station as well. So clubbing, chylonychia, this is for iron deficiency anemia. Scars from cannulae, again in thalassemia. Pallor, assess pulse rate and volume. If there are any concerns, then check blood pressure. Otherwise, you would mention checking BP later. So normally pulse rate will be checked, just rate and volume. No need to go into details. And if you have any concerns, you can go for BP. Okay. Like otherwise, you could mention checking BP later. Think symptomatic anemia. Although it could be uncommon in the exam scenario, you may be asked to talk about it. Okay, but now it's online, it can come. The symptomatic anemia also can come. Any case can come. So head and neck, again, frontal bossing and malar prominence. This frontal bossing and malar prominence mainly in thalassemia. Eyes, you see pallor or jaundice and conjunctival hemorrhages. Lymphadenopathy. Lips, angular cheilitis. Look at the gums, hypertrophy in neutropenia, and look at dentition, tongue, and tonsils. So again, frontal bossing and malar prominence in eyes, pallor, and jaundice. I did not understand conjunctival hemorrhage for thrombocytopenia again, or even in, leukemias or something.
Yeah, this is the same like as I mentioned in the morning. Any mass is there, and that's why this is conjunctival.
Yeah, means maybe anything which can bring about thrombocytopenia, maybe TAR
Right.
syndrome or leukemia, lymphoma. And lymphadenopathy, again, to rule out the malignancies. Lips, angular cheilitis. Look at the gums, hypertrophy. You can see neutropenia, and dentition and tongue and tonsils. Next, chest, you have to look for the Hickman line or Portacath. Heart murmur, flow murmur from anemia. Comment on presence or absence of increased work of breathing, that is distress. Why this distress commenting is important? Think of sickle chest syndrome, which is unlikely to be present to clinical exams, but it is important part of examination. Okay. So distress, you can think of sickle chest syndrome in a case of sickle cell anemia, and there can be flow murmurs in the heart in cases of anemia, and also any Hickman line or a Portacath, you have to comment on that. Then abdomen scars, including laparoscopic. They could have done splenectomy or cholecystectomy. So you should know about the scars. Bruises from injection sites. And liver, spleen, inguinal lymph nodes. So you will palpate for the liver, spleen, inguinal lymph nodes, bruises from the injection site. Then legs, you will see for signs of infection, scarring or bruising, joint disease. If the joint swelling, you can think of hemophilia. Again, scarring and bruising, again for reduced thrombocytopenia, maybe leukemia or TAR syndrome, any signs of infection. Then finally, axillary lymph node. So axillary lymph nodes, you have to check. Very difficult if children are even slightly ticklish. So leave until the end, but don't forget about it. In a boy, you would normally palpate testes. Indicate to the examiner that you would like the examination by doing this. Okay. So if there is a case, if you suspect the case as leukemia or something, you have to offer for palpation of testes. Indicate to the examiner that you would like to complete the examination by doing this, that is natal examination, looking for testicular lymphoma or testicular relapse of hematological malignancy. So there can be testicular lymphoma, or maybe this is the malignancy. I'm not getting the word. What we say? Metastasis, right? Does they mean the same thing? Testicular relapse of hematological malignancy. This may be the metastasis or what?
No, recurrent thrombosis in the testicular patient. They will come with hemiplegia or double-plegia.
What thrombosis you mean?
Yes. Vein occlusion.
Veno-occlusive crisis like this.
Yes, exactly.
Okay. So in neurology, neurological examination, especially in children with sickle cell disease, check temperature, crucial for neutropenic and immunodeficient patients. Mention that you would like to plot height, weight on growth chart, and do parents have evidence of the disease? So here, some of the important things is we'll just go through fast. This is general examination, which we all know. Here only one more thing, if you're thinking of TAR or Fanconi's, there can be some upper limb deformity that you have to keep in mind. And also if there is thrombocytopenia, there can be bruising, petechiae, purpura. And you will offer only BP. Usually you will offer for BP, but just check pulse rate and volume, and regular hand testing, what we discussed in the morning. Then frontal bossing malar prominence. This is for thalassemia. Pallor, jaundice, conjunctival hemorrhages, lymphadenopathy, anything in the mouth, including ulcers, glossitis, stomatitis, cheilitis, everything has to be checked. Gum hypertrophy, you can see in neutropenia, and also dentition has to be common. Tongue, tonsils. In the chest, they may have Hickman line and Porta-Cat, and flow murmur of anemia. And there can be distress in sickle chest syndrome. Scars, including laparoscopic. If there are multiple, you have to observe for splenectomy and cholecystectomy. Bruises at the injection sites, liver and spleen palpation, inguinal lymph nodes. So we studied all lymph nodes are coming from cervical, axillary, inguinal, all lymph nodes has to be palpated. Any signs of infection, scarring or bruising, joint disease. Then axillary lymph nodes, you have to palpate without fail. And testes, you have to offer to palpate the testes, because they can be testicular lymphoma, or you may have some metastasis or vaso-occlusive crisis. Then neurology for sickle cell disease, temperature in case of neutropenic and immunodeficient patient, and plot height and weight on growth charts. Okay. I'm keeping that.
Okay, let me know. Just let me know when to start. Huh?
Yeah, it's just 6 minutes, right? In 6 minutes, you have to finish off and come to in order to complete my examination, right?
Yeah.
And then in 6 minutes, you have to finish. Then DDs and investigations and management for 3 minutes.
Yes.
So, okay, you can start now. Start.
Okay, I will greet the patient and mother, introduce myself, will take the permission for examination. After gel my hands, will talk to patient to build good rapport, will try to make him comfort, will assess his learning capability as well. Then we'll take journal look to see if he's alert, sick looking, well looking. We'll see if he's any obvious unusual features. We will assess his journal built in terms of height, weight, and head circumference, and also see in the surroundings for anything or
Okay.
any tab.
Okay, he is well looking, well communicating, and short for his age. And for the face, you can see to describe.
Yeah,
And no
yeah,
devices, only IV cannulation also is there in
yes.
the picture, which you can
Yeah,
count.
that was it. Then I will start my examination from hands. We'll see for clubbing, leukonychia, palms, for the pulmonary erythema, pallor, and flapping tremor. Then we'll see back of hands, arms for any cannulation scars. I can see there is this cannula is there, and would like to see bruises or trichia or pigmentation in the arms as well as for AV fistula.
Yeah, only pallor is there in the hand. And anything else you want to check apart from what you said? Pulse.
Yeah, I'm coming to that. Also check for the pulse, rate, rhythm, character, and volume.
Okay, regular 80 beats per
Okay.
minute.
Okay. Now I'll move to the face. We'll see for the pallor or jaundice in the eyes and
Yeah,
nose.
you can see this picture first.
Yes.
Uh,
There is. I can see there is jaundice and the
yes.
looking pale for me.
Okay, yes. Next.
So then I will see for the any unusual features on the face, in the especially in the eyes, in the nose, in the ears, in the mouth. Then I will move to the mouth for check the dental hygiene and any ulceration is
No,
there
the
or format. Okay,
mouth is normal.
okay.
Next.
Then I will move to the neck to see for any engorgement of the veins, any scars or visible pulsation. No, I will move to expose the child after getting permission by keeping modesty of the child in mind. We'll see for any scars, any gynecomastia, spider nevi, any long line in the chest.
No scars, no spider navy, no long line. Next.
Now we'll ask the child to lie down flat on the bed if he's comfortable and start inspection of the abdomen from the three sides, from the foot end and these from the sides by leaning to the ground myself. And I will looking for any surgical scars, any rashes, dry, visible veins, caput medusae, or any hyper or hyperpigmentation or swellings.
No distension, no caput medusae, no obvious swelling seen. Okay.
Okay.
Yeah, there
After
is
that,
one scar. Yes, there is one scar below the right hypochondriac region, small scar.
small scar is there.
Yeah, around
Okay.
2 centimeters.
This is transverse or oblique or what?
Transverse. Transverse.
Okay.
Coachers, like
After that,
coachers incision.
okay. After that, we'll start palpation. After asking for any pain from the patient, we'll do superficial palpation starting from the left side in the S shape, and the same time we'll look to the child face in the eyes if he's feeling pain or not. Okay.
No pain. He's pain free and breathing comfortably.
Okay. Then I will start a deep palpation. First, I will tell the child and ask him to take a deep breath during the inspiration. I will put and will go to the deep. First, I'm looking for any hepatomegaly starting from the left iliac fossa coming to the upward.
Right or left?
Sorry, right.
Right,
So,
yeah. You could not palpate the liver.
okay. Then okay. So then I will check for the spleens starting from the right iliac fossa towards obliquely coming to the left hypochondrium, looking for palpating for spleen.
Yes, you can. There is a splenomegaly. You can appreciate. It's 3
How
centimeters.
is the margins? How are the margins of the spleen? Is there any this painful or?
No. You can feel the notch, but otherwise the margins are smooth. It is 3 centimeters below the costal margin. But I want to ask, how do you confirm that it's the spleen?
Yeah, if I will not be able to go above it, and this moving with the respiration, and I will feel the dullness with the
Okay.
percussion, and as you told me, the notch is there. So this is
Okay.
spleen.
Next.
And then I will check for the uh, kidneys by manual, putting my left hand below, pushing the right hand above, and pushing by my left hand, palpating for the kidneys. If
No.
there,
No kidneys palpable.
then we'll check the shifting dullness by percussion below the umbilicus toward the bladder. Then we'll come to the left side and we'll
No, there is no
shifting
abdominal
dullness.
distension, so no need for the shifting dullness. Next, what do you want to do?
Okay. Now we'll do the auscultation for bowel sounds and buoy for liver and renal. Also check for the pedal edema. Now I will ask the child to sit and start inspection of the back for scars, swelling, palpate for spine and renal angle as well.
Okay, no other findings you got. Bowel sounds are normal and all other findings you did not get. So 6 minutes finish. Tell in order to
Okay.
complete.
In order to complete my examination, we'll check for the lymph nodes, hernial orifices, and genital and anal examination. And plot his height and weight on the appropriate growth chart, and would like to do his blood pressure as well. And we'll do the examination for the gait examination as well. This is for my diagnosis. And
Okay,
we'll do the chest examination as well.
okay. So give your
So today I have, what was the
presentation.
name? What was the name?
Name was Yap.
Yeah. Okay. Today I have examined. Yeah. Now he's 8 years old. He's small for age, and he's well looking. He's well looking and small for his age, and looking paler. Paler. There is no signs of chronic liver disease, and no clubbing. And he's having paler, and as I can see, he's having this IV line in situ, and with the jaundice and pallor in the eyes. And I could not find any uh, signs of chronic liver disease on the inspection of the chest and the abdomen. There is splenomegaly, that is, there is a scar on the right hypochondrium, that is small scars, that is like a bleak scar. And there is splenomegaly with the notch 4 centimeter below the left costal margin, and the rest of the examination is unremarkable. So putting all together, this is for me, this is a chronic hemolytic anemia, and most probably my diagnosis is here, as the child is 8 years old. So hereditary spherocytosis.
Okay. Any other differentials?
I can put it here, other chronic hemolytic anemias and infections as well, like chronic any chronic infections or acute infections and leukemias. But I will negate it, as there is the spleen is there, so sickle cell anemia is very less likely at this age. And there is a scar that is most probably due to the gallstones, or cholecystectomy scar is there most probably. So there is no liver, so thalassemia is ruled out. And again, there can be some of myeloid leukemias where spleen can be palpable. and there is pallor is there,
Mm.
and child is having infections, but again this is there is a scar, so it's not coming fitting with my myeloid leukemia, and the age is also not suitable for that. And again infection can I put here, like malarias can associated with that, but again there is a scar, and the child is small for his age, so it's not also coming with that. So most probably diagnosis for me is hereditary spherocytosis.
Okay, so if this is a hereditary spherocytosis, how do you want to manage this, investigate and treat this child?
Yeah, first I will take the history and will take the vitals of the child, and after that I would like to do some test like in the form of CBC and with the peripheral smear where I spherocytes I would like, I mean to say the spherocytes I would like to see, and there can be some uh, uh, like poikilocytosis. I would like to do the retics count also, and uh, as the child got this pallor after the infection that is mentioned in the, so I would like, I will consider for bone marrow also, and osmotic fragility test, but now it's obsolete, and there is another which I forget the name, and now they are using this really I forget, MLA or HL something.
Osmotic gradient test, you mean?
No, osmotic fragility test they were doing before, but now it's not, they are not doing. So in the CBC, MCHC will be higher, especially in hereditary spherocytosis. For the management point of view, I would like to see if this is not, if the child is not in the aplastic crisis, I would like to involve my consultant, like, and yeah, EMA test. Dr. Iman said this is EMA test. Now they are doing. So I would like to involve here hematologist and again the gastroenterologist, and definitely immunologist because splenomegaly is higher, and the social worker, as well as would like to do blood grouping also, blood grouping and save the blood.
Okay, apart, you said FBC and peripheral blood smear. Anything else you want to do?
Retic count, I told that, and then I will
Okay.
do the total bilirubin and
Yeah,
uh,
liver function
yeah,
test you want to do.
yes, yeah, liver function test I would like to do, and again this for if very less likely that there is infection, but still I will consider for the malarial parasites also,
About your
because this,
differential diagnosis, anything else you want to,
yeah,
apart from malarial parasites?
uh, from this bone marrow, which I am thinking for the parvovirus B19, because suddenly doctor this child developed this anemia after a viral infection. So I would like to go for that also.
Okay. Why you said immunologist in this case for multidisciplinary team?
Immunologist, I just uh, put in mind for this splenomegaly is there. So would like to see for if there is any hypersplenism. That's why I was looking for the immunologist also.
Okay. Okay. Do you want to do any antiglobulin test for her, direct antiglobulin test?
Yeah, we can go for to check we can go for to check there is a hemolysis or not for this retics, and this direct Coombs test we can do, and what LDH level we can do. So all these will tell us about that hemolysis is there or not.
Okay.
And one more differential which I was thinking that I will put here autoimmune hemolytic anemia also.
Yeah, that's why to rule out, you have to do this direct antiglobulin test here.
Yes, yeah,
This is for your differential. Okay.
yes,
So does hereditary spherocytosis, will the hemolysis increase with infection?
yes.
Yeah,
It
here.
can increase the infection, and there was a scar as you told me. That's why hereditary spherocytosis. If you did not tell me, So I will put in mind autoimmune hemolytic anemia or any infection is there like malarias or other infections,
Yeah.
leishmaniasis or something like this.
No, here it was just his condition was means he came for upper respiratory tract infection, but it was accidentally diagnosed because of his CBC, mild anemia, and there was slightly jaundice. That's why he was investigated. It's
Yeah,
like
yeah, this.
infection. He was precipitated little more like this. His
Yes,
spirocytosis
yes,
was
definitely you are right. But
infection. This was
still we
the
should consider.
yeah. It's okay. You have to give the differentials for sure.
Yeah, I will give the differential and will negate the same time.
Yeah. Okay. So anyone wants to add anything to what Dr. Rohel said in for investigations and management can go ahead before we go to know about.
On Mark, they mentioned other differential diagnoses include hereditary erythrocytosis, pyruvate kinase deficiency, autoimmune hemolytic anemia, as Dr. said.
Yeah, autoimmune hemolytic anemias, but again, there is a scar, so that's why I was not thinking of that. So infections, I can think of that in the hemolytic anemias. Actually, we'll have if you are finding only the spleen, so we'll have to think of infections also. Actually, Dr. Noor, what I was thinking as you have given me the scar, so I was thinking this will be a known case. That's why I was thinking this infections like parvovirus B19 or something like this. That's why I was coming to that because this scar is there. So this is specific. You told me culture scar. So why they have done this? Definitely there was gallstones or cholecystitis that has been removed now. So if the child at this age is having this kind of, so definitely someone will go for that investigation also. So we cannot say that this is a new case and just they have got this case and after the viral infection they got this anemia and pallor and jaundice. So there will be no scar then. I think so.
The scar is the clue for you here. There are two clues. One is the scar, particularly in the Kocher's incision, means it is going with cholecystectomy. And another thing is after URTI, it's increased, or the child came for URTI evaluation and he was evaluated for that, or maybe because there is Kocher's incision, it was increased. Maybe the jaundice is increased due to increased hemolysis due to infection. Okay. We'll just go through this hereditary spherocytosis. Then again, we will go through the management from patient info, just important points. Okay.
Okay. Yesterday exam this case came. But there was very huge spleen was there. I think 8 or 12 centimeters somebody was telling.
Okay, I don't know actually. I knew that the hereditary
There was no scar actually. There was no scar.
I knew that hereditary spherocytosis came, but I don't know the details still. Which anyways, we were doing abdominal station, so I thought it's a common case we will do.
Yeah, it's very common.
So this is very common clinical case in examination. Tip Northern European child plus pallor, jaundice and splenomegaly. So one of the thing, again, we were reading ethnicity, right? So usually European children will be there. But this case I presented was from Thailand. So that's why I gave the name as Yap. Okay.
For that I put malaria also. Really, I told you.
Okay, so usually it will be Northern European child plus pallor, jaundice, and splenomegaly. Hereditary, any child with this ethnicity and having pallor, jaundice, and only splenomegaly, it is hereditary spherocytosis unless proved otherwise. So your top of the differential will be hereditary spherocytosis. Three things remember: pallor, jaundice, and splenomegaly, and the ethnicity, the North European child. Next, instructions to candidate can be: examine this child's abdomen. Why is he jaundiced? Okay. Or this boy presents with abdominal pain, pallor, and palpable spleen. What are your thoughts? What would you do? So Northern European child looks well, jaundiced, mild usually, pallor, cholecystectomy scar occasionally there can be, splenomegaly or splenectomy scars can be there. It can be normal splenectomy by laparotomy or the laparoscopic. Any scar can be there. So you have to observe for all these things. If you think that it is hereditary spherocytosis, cholecystectomy scar for splenomegaly or splenectomy scars as well. So there are two cases they have told. This is well-looking boy. I would like to examine him. His conjunctivae are pale and he's mildly jaundiced. He has a palpable spleen. There are no other abnormalities. I suspect he has hereditary spherocytosis. Okay, for example, when you're presenting, you can say that this is a well-looking boy. He has pallor and jaundice in his eyes, or conjunctiva is pale or jaundiced. He has a palpable spleen, and whatever is your measures, you can tell. There are no other abnormalities. I suspect hereditary spherocytosis. Another, this is a well-looking boy. There is no pallor or lymphadenopathy. He has cholecystectomy and splenectomy scar. Some children who have already been operated for that. There is the underlying diagnosis is most likely hereditary spherocytosis. If there is both cholecystectomy scar and splenectomy scar, no pallor, maybe because he is improved. There is no splenectomy and no too much destruction of cells. Okay. So they are also asking inheritance of some conditions. You should know about it. Okay. It's an autosomal dominant condition. Incidence is 1 in 5,000 Northern Europeans, more commonly, usually presents in childhood with classic triad of anemia, jaundice, and splenomegaly. So in our case, we presented, there was anemia, there was jaundice, and splenomegaly. Okay. So one thing is ethnicity, and with these things, pallor, jaundice, and splenomegaly, think of hereditary spherocytosis. The jaundice is unconjugated and worsens during infections. So what happened here? When he presented with upper respiratory, it is increased and it became obvious. Okay, so the jaundice is unconjugated and worsens during infections. Pigmented gallstones are present in 85% by second decade. Okay, so usually they may have gallstones. And he's telling by 20 years of life, 85% will have the pigmented gallstones. Aplastic crisis can also occur. So this also you have to keep in mind about the aplastic crisis.
Yeah, I have told you. For that, I have involved this all immunologist.
Yeah, one thing you have to always remember, whenever there is infection, the condition can worsen with increased jaundice, and it can become obvious. Okay. And aplastic crisis can also occur, and most of them will have pigmented gallstones by 20 years of age. Okay. There are guidelines on diagnosis and management from British Committee for Standards in Hematology. The diagnosis is based on combination of typical clinical history plus family history, because this is autosomal dominant. Okay. Either mother or father may have it. So there will be family history, typical clinical history, examination, and full blood count and blood film picture of spherocytosis. In a typical case, there will be spherocytes seen on the film and increased number of reticulocytes. So your finding on, if they ask you your investigations and what is your finding on the blood film, you have to tell that there will be spherocytosis and also increased reticulocytes. Okay, in typical case, it will be obvious for them, the spherocytes and increased number of reticulocytes. And also there will be family history of the condition and typical clinical history. Treatment, as with any hemolytic anemia, you have to give folic acid. Okay, folic acid supplements unless it is mild, with regular monitoring of clinical state and blood picture. So blood picture has to be regularly monitored, and also folic acid supplements. In severe cases, particularly where symptoms, example gallstones and significant anemia, are impacting on quality of life. Okay, there is in spherocytes are more, and there is too much of destruction of blood cells, and it is causing anemia, and it is impacting the quality of life, then you will go for splenectomy. So what is the indication for splenectomy here?
Actually, indication is for splenectomy in hereditary spherocytosis if it's giving the more discomfort to the child, one thing, and the distraction is more. That's why his child is unable to do his daily activities, like reduces the quality of life.
Yeah, as he said, impacting the quality of life with significant anemia.
So one more, if you will add, then it will be in the thalassemia. If the requirement of the blood per year is more than 200 milligram per kg, so this will be
ml, I think
200 ml. Yeah, 200 or 250.
40.
Some books are saying 180, some 200, some are saying 140 also even. So there are different.
Okay.
Per year.
So approximately 200 to 250 ml.
Yeah, 200 to 250.
Okay. Thus, so it is impacting the quality of life. Then splenectomy you have to consider. The spleen is the site of red cell destruction, and its removal will reduce hemolysis and reduce the incidence of gallstones. So how the splenectomy will affect in these children? There is destruction of red blood cells in spleen. So its removal will reduce the destruction of red cells. Despite they are spherocytes, their destruction is reduced, and there is incidence of gallstones is also reduced. So cholecystectomy is occasionally required, particularly if there are already symptomatic gallstones. It means a child is suffering from continuous pain in the right hypochondrium due to gallstones or vomiting or precipitating cholecystitis like this. If there is symptomatic gallstones, they will also go for cholecystectomy. And splenectomy is indicated only when there is significant anemia impacting the quality of life and also symptomatic gallstones. Because the reason is splenectomy will reduce both the destruction of the red blood cells and the incidence of gallstones. Once a child is asplenic, okay, so suppose you did splenectomy and now the child is considered as asplenic, there is increased risk of pneumococcal and other infections, that is pneumococcal, meningococcal, and HIV. Immunization and lifelong prophylactic penicillin needs to be given. So when they are asplenic, you have to consider all these: pneumococcus, meningococcus, and HIV immunization and prophylactic penicillin. So same like the medications, same like sickle cell, here is the prophylactic penicillin, that is penicillin V, and folic acid. You will also give folic acid to them. And immunization with pneumococcal. So differential diagnosis here, he has given hereditary elliptocytosis, autoimmune hemolytic anemia, and pyruvate kinase deficiency. This pyruvate kinase deficiency, it presents same like hereditary spherocytosis.
It present very early age. In the neonatal period, I think so. This elliptocytosis, the same kind of this spherocytosis, this is the shape problem. But pyruvate kinase deficiency is presenting earlier.
Okay, so for us, we can put this autoimmune hemolytic anemia as the differential and hereditary elliptocytosis, and also infections if the child, based on the ethnicity of the child. I don't know, anyone has this guideline, BCSH guidelines, British Committee on Standards in Hematology. Let me check.
Yeah, I have checked, Dr. Noor. They are saying for this pyruvate kinase is early life. This is limited to the early life usually. Most of the child may have death in utero also due to anemias. So sometimes may require splenectomy, but mostly symptomatology is limited to early life.
Okay. Investigations and management is very important. We should be up to date about it. Maybe the presentation of the diseases will be same, right? But the investigations and management, you have to go for any recent, from any recent source always, so that we'll not miss it. So the investigations here, as we read in the mark, family history and clinical picture will support you a lot. Most patients can be diagnosed on the basis of family history, typical clinical features, and laboratory investigations. All these will support each other. That is the positive family history, typical clinical features in the child like pallor, jaundice, and splenomegaly. Laboratory investigations such as spherocytes, and you should always know what is your interpretation, like Dr. Rohel was telling, MCHC, okay, mean corpuscular hemoglobin concentration, right? It will be raised usually. And also there will be increased reticulocyte count, both if you send for retics as well as in the blood picture, you can see increased reticulocytes. So if this much is there, they don't require additional tests, he is telling. If what are the criteria now? Family history, second is the clinical history, then third is the CBC and blood picture. Okay, So CBC is showing anemia for you, and blood film is showing spherocytes, okay, with increased reticulocytes. This will give you the diagnosis, okay, if you want, and even the raised MCHC concentration. This we will get in CBC only, right? MCHC value will get normally in CBC itself. So this we will keep basic. Anything else if we want to know, like again, FBC and blood film, he's giving here the interpretation, including reticulocyte count. Spherocytes and reticulocytosis are seen in peripheral blood film. FBC shows MCHC and increased red cell distribution width as well. Both you have to remember, MCHC and RDW, both is increased.
Yeah.
Then LFT, because jaundice, whenever the child is jaundice, you will request LFT. This we have to remember, that's it. And it will indicate for you the hemolysis, like increased unconjugated bilirubin, lactate dehydrogenase, and urinary and fecal urobilinogen with reduced haptoglobin levels. Normally what happens, any jaundice child, even the newborn baby, when we check the TSB and DSB, the total serum bilirubin, usually like how it will be in that children. Similarly, here we will have unconjugated bilirubin, and also you will get urobilinogen in the urine and feces. Okay, and lactate dehydrogenase will be raised, right? What else?
This, yeah, LDH, I told you, this is for indication of the hemolysis. Actually, LDH will be raised.
LDH and reduced haptoglobin levels, both, or the indications for hemolysis, right? And even urobilinogen, the presence of urobilinogen will again give you that there is bilirubin in the increased bilirubin in the body.
LDH will be raised, not reduced. Will be only haptoglobin.
Yeah, LDH will be raised, reduced will be haptoglobins, and there will be raise in the urinary and fecal urobilinogen. All this is because of hemolysis. That is what he is telling. LFT is indicative of hemolysis. Next, you will do for your differential direct antiglobulin test, you can tell is usually negative in, if it is negative, it favors hereditary spherocytosis, but positive in autoimmune hemolytic anemia. For your differential, you do direct antiglobulin test, and now osmotic fragility test is unreliable and is no longer recommended. So you will not go for it.
Yeah, as I told you, this, they are using now EMA.
EMA. Okay, maybe it's there further. Osmotic gradient ectocytometry is used to differentiate HS from hereditary stomatocytosis, but it is available only in special. I don't think this we have to mention. It's not needed for us, right? So we will go for others. If the diagnosis is equivocal, you are not sure of the diagnosis, a screening test is helpful. The recommended screening tests are cryohemolysis test and EMA binding. This is what you are telling?
Yes.
SDS polyacrylamide gel electrophoresis on erythrocyte membrane proteins is carried out to confirm the diagnosis of atypical hereditary spherocytosis. Okay, so EMA binding test, this is called.
Yes.
So that's all. He did not give much in the investigations. It is very simple to remember. As we read first, for the diagnosis, this triad is enough. The family history, the clinical picture, and FBC and blood film. Like FBC showing increased MCHC and also increased RDW, and blood film showing spherocytosis and increased reticulocytes. This is more than enough for your diagnosis. But when you are not sure of the diagnosis, then you can go for other things like this direct antiglobulin test to rule out autoimmune hemolytic anemia, and this EMA binding test. Okay. Apart from that, nowadays don't mention about osmotic fragility test. For your supporting of hemolysis, you can tell LFTs. In LFTs also, you will tell that increased unconjugated bilirubin, then increased lactate dehydrogenase, and decreased haptoglobin levels. Okay. And also you'll see urinary and fecal urobilinogen. Can anyone tell me about this EMA test, what they do? Any idea? No problem. We can see and understand. Anyways, it's a screening test. We have to remember the name here. There are two tests he's mentioning. One is cryohemolysis test, like osmotic fragility test. This is also an hemolysis test, cryohemolysis test, and EMA binding. As I understand, cryo means cold. So maybe under this of cold, there can be hemolysis. I'm not sure. We can go back and check these two tests, cryohemolysis and EMA binding test, okay? Because they will ask you in investigations for this case, you should know. Next is the management. Once the diagnosis and baseline severity are established, once the diagnosis and baseline severity are established, it is not necessary to perform repeated blood test unless there is additional clinical indication. As I told you, we should know the basic criteria to diagnose hereditary spherocytosis. No need to perform once you confirm the diagnosis, additional tests. It is not necessary to perform repeated blood tests unless there is an additional clinical indication like intercurrent infection, pallor, and increase in jaundice. A routine annual review is usually, they will be following up every year annual review, but you will see the patient only if there is intercurrent infection, increase in pallor, and jaundice. That means the hemolysis is increasing. And also if there can be a aplastic crisis. So you have to see. An open door policy for potential complications such as parvovirus infection or abdominal pain, which may trigger investigation for gallstones, is a good practice. So you should always keep in mind the potential complications of parvovirus infection, and also the abdominal pain in these patients can be from the gallstones. You have to rule out whenever they present with abdominal pain. Mild cases do not usually require folate supplements or splenectomy. As we said, the indications: significant anemia causing impact on the routine activities, then only you will go. Otherwise, mild cases, no need folate supplements or splenectomy. Steroid therapy may be effective in augmenting hemoglobin levels during hemolytic crisis in patients with moderate disease, and will result in the patient requiring fewer transfusions. So steroid therapy can help these patients during acute hemolytic crisis, okay, and will result in patient requiring fewer transfusions. Since it's given in patient info, if needed, you can mention, no problem. It will prevent the requiring of transfusions, okay. So splenectomy, you should know, very important. Moderate to severely affected individuals are usually given folate supplementation and offered splenectomy. So for mild cases, no need of folate, no need of splenectomy. For moderate to severe, you need folate supplementation and splenectomy. Splenectomy eliminates anemia, hyperbilirubinemia, and lowers high reticulocyte number to nearly normal levels. So pallor is reduced, jaundice is reduced, and reticulocytes become normal. Treatment of hereditary spherocytosis with splenectomy is curative in most patients, but increased recognition of long-term risks of splenectomy has led to re-evaluation of the role of splenectomy. Definitely splenectomy will help these patients, but as we know, asplenia, hyposplenism is the complication which makes us to rethink to consider splenectomy. Okay, a laparoscopy approach should be used, that we know. This is usually performed after the age of 6 years. So even indication splenectomy is usually performed after the age of 6 years, and even partial splenectomy can also be done. It can be beneficial if you are afraid of the negative effects of splenectomy, like capsulated organism infections like this. If children are having a splenectomy, and the gallbladder should be removed at the same time if there are symptomatic gallstones. However, if children are having cholecystectomy for symptoms of gallstone, concurrent splenectomy is controversial as it is associated with risk of post-splenectomy sepsis. So whenever you are planning for splenectomy and there is already symptomatic gallstones in the children, you can remove it. But if you are removing gallstones for the symptomatic gallstones, if you are doing cholecystectomy, you have to think of splenectomy. Again, as I told you, the complication post-splenectomy sepsis, you have to consider whether they really need splenectomy or not. Post-splenic embolization may be considered. Splenectomy should be avoided in patients with some forms of hereditary stomatocytosis. I think, is this hereditary stomatocytosis? Is this the differential diagnosis for this? I don't know what it is. So I don't think we will go it. We'll just see the complications again: gallstones and gallbladder disease. Coexisting Gilbert syndrome can increase 4 times increased risk of gallstones, and the increased risk is abolished by splenectomy. Can someone, if anyone remembers about Gilbert syndrome? I think it's there in Mark. I remember reading long time back. It will increase the risk in these patients. So splenectomy, and he has written that 4 times increase in risk with gallstones, and splenectomy has to be considered. Other complications is the hemolytic, aplastic, and megaloblastic crisis. Rapid hemolysis can be triggered by viral infections. So you have to be very careful. If the history is given that the child has fever, it can be precipitated. Rapid hemolysis can be triggered by viral infections and produce jaundice, anemia, and occasionally abdominal pain and tender splenomegaly. Supportive treatment is usually all that is needed. Aplastic anemia or crisis can follow viral bone marrow suppression and can be life-threatening. The most commonly caused infection with parvovirus B19 usually lasts 10 to 14 days. Megaloblastic crises are rare and due to folate deficiency. That's why you have to supplement with folates. So prognosis is good. Only 3 to 5% patients will have severe disease who require regular blood transfusions. Prevention, genetic testing, always multidisciplinary team in all the 3: sickle cell, thalassemia, and hereditary spherocytosis. We have to involve geneticist. So prevention, genetic testing, and family tracing are available. Relatives who are carriers of gene may show persistent reticulocytosis. But how they will be carriers here? It's an autosomal dominant condition, right? Is there any component of autosomal recessive also in this disease? So any comments?
Yes, it can be autosomal recessive as well, but in very less.
So if children undergoing splenectomy, the gallbladder should be removed concomitantly if there are symptomatic gallstones. If stones are incidental finding without symptoms, the value of cholecystectomy remains controversial. If gallbladder is left in situ, including the cases when cholecystectomy with stone extraction is done, close follow-up using ultrasound is necessary. So just remember that if there is symptomatic gallstones, when you are doing laparotomy for splenectomy, even gallstones will be removed. Children who require cholecystectomy for symptomatic gallstones, the use of concurrent splenectomy is controversial. Same thing we read in the patient info. When splenectomy is indicated, ideally it should be done after the age of 6 years. This is very important to remember, okay? Whenever splenectomy is indicated, it should be done after the age of 6 years. There is no indication for extended thrombosis prophylaxis after splenectomy in patients with HS. So no indication, so no need to remember this. Splenectomy should be avoided in patients with some forms of hereditary stomatocytosis due to increased risk of venous thromboembolism. Anyone has idea about what is this hereditary stomatocytosis? Should it be put as the differential for this? No problem, we'll go and check. From this, no need to read, it's very big. I think the patient info has covered the information, whatever is there in this important information. This is one of the reference from there I took. Whatever is in here, bold letters, this is important for us for the exam, that you will go for splenectomy, and partial splenectomy is the recent development. And gallbladder, if it is symptomatic, you should remove simultaneously with splenectomy. If it is not, it is controversial, it will be decided by the hematologist. Next, after the age of 6 years, splenectomy is indicated. Very important. And another thing is this hereditary stomatocytosis. I don't know what it is. You have to avoid it. We have to check about it because in 2-3 places we read. And for diagnosis, main thing, family history, clinical features, and spherocytes in blood film, raised MCHC and raised RDW in CBC, and reticulocyte count increased is enough for diagnosis. If you are not clear, then only you will go for EMA binding test or cryohemolysis test. That's it. This much is more than enough to remember for the diagnosis. Okay. On examination of his abdomen, he has palpable spleen, and also they will also have hepatosplenomegaly, both. Okay, he hasn't given here, I don't know why. Usually they will have multiple scars of IV cannulae and sclera, jaundice, and also there will be palpable spleen and some depigmented patches on the abdominal wall. I just want to ask, how will there be the patches of the desferoxamine? Anyone has idea? It will be hypopigmented, right? I don't think it's hyper, it's hypo. I just want someone to confirm it's right or wrong. I don't know really. Depigmentation means what? No pigment, right? So it's hypo. This is what I am thinking, but Just check it, okay? I also noticed that he has some patches of depigmentation on his abdominal wall. This child has thalassemia major. I would like to plot his height, weight on growth chart and check his pubertal status. So usually ethnicity, there we read for hereditary spherocytosis, Northern European. Here they will be Mediterranean, African, Indian, Southeast Asian child. So Indian, Southeast Asian child and also Mediterranean child, sometimes can be African as well. Multiple IV cannula sites on the hands, and they may also have a portacath. You have to look for the portacath. Jaundice, mild, and also pallor. Multiple depigmented patches on the abdominal wall from subcutaneous desferoxamine administration. Usually subcutaneous desferoxamine is given to these patients, and so you will see multiple depigmented patches on the abdominal wall and a palpable spleen. The above refers to this patient. What they are referring is the above refers to a well-controlled child with thalassemia on regular transfusion regime. Children who have severely affected may have signs of extramedullary hemopoiesis. Means sometimes the children who are well controlled with regular transfusion, you may not see this frontal bossing, malar prominence, all those things. And also here in this case, he hasn't given hepatomegaly as well. Only splenomegaly is there. Okay. But he has desferoxamine depigmented patches in the abdomen, and also he has multiple cannula sites in the hand. Okay. So he is a well-controlled child with thalassemia major. Children who have been severely affected may have signs of extramedullary hemopoiesis. These are frontal bossing, molar hyperplasia. You will, and in the abdomen, you will check for hepatomegaly, splenomegaly, and also there will be previous long bone fracture sites. Okay. So all these are the signs of extramedullary hematopoiesis. Suppose if this is a history case, you have to ask for all these questions. If anything which can be asked in the history, like any facial features mother is noticing, or anytime he had fractures, all these questions has to be asked. Frontal bossing, malar hyperplasia, hepatomegaly, splenomegaly, previous long bone fractures. These are all the indications for extramedullary hemopoiesis. The thalassemias are a heterogeneous group of recessively inherited disorders. So it is an autosomal recessive disorder characterized by deficient synthesis of either alpha or beta chains of hemoglobin. The various different types, and there are approximately 100 different mutations of known to cause thalassemia, many of which are unique and localized to geographical areas. These notes on transfusion-dependent major form of beta thalassemia. This occurs in populations mentioned above and is often diagnosed antenatally after routine newborn screening tests. Either these thalassemia can be diagnosed antenatally or by routine neonatal screening tests, which will be done immediately after birth. I think 5th day of birth, right? Guthrie's test usually done on the 5th day. Okay. There is a globin chain imbalance that results in ineffective erythropoiesis. So globin chain imbalance that results in ineffective erythropoiesis and severe progressive hemolytic anemia during the second 6 months of life. The anemia is microcytic and hypochromic with poikilocytosis and target cells on peripheral blood film. There are large number of nucleated red blood cells and marked increase in HbF. There is iron overload with increased absorption of iron from GI tract. So what usually happens here? There will be globin chain imbalance, and because of that results in There is erythropoiesis happening, but it is ineffective. So there is extramedullary erythropoiesis, which is increasing. And also there is hemolytic anemia, and which is more seen in the second 6 months of life. Microcytic hypochromic, same like you have to differentiate here from iron deficiency anemia. Okay, but the peripheral film will also have poikilocytes, target cells, and also nucleated red blood cells. And there is, if you do electrophoresis, there will also be increase in HbF. There is iron overload with increased absorption of iron from GI tract. So clinical features vary with severity. Undiagnosed children who have become severely affected can present with pallor, jaundice, faltering growth, feeding difficulties, and hepatosplenomegaly. Suppose if untreated children presenting to you for the first time may have severe pallor, jaundice, and hepatosplenomegaly, even massive sometimes. If untreated or inadequately transfused patients, there is proliferation of medullary and extramedullary hemopiosis with massive expansion of the skull and face. So if you left them untreated, this extramedullary hemopiosis will cause with medullary and extramedullary both. So medullary means inside the bones, will cause massive expansion of the skull and face, causing characteristic faces of frontal bossing is a classic sign of this. Bones can become affected. So what happens due to this medullary hemopiosis? The bone marrow is expanding and it is putting pressure on the bones, right? So there will be osteopenia and osteoporosis, and children can have pathological fractures. Because of the expansion in the medulla of the bone, they will have this osteopenia and osteoporosis, and they can have pathological fractures, and this can be the presentation. Like in the history case, there is a celiac disease presenting with fracture, which also has osteopenia and osteoporosis. Even the thalassemia can come like this. Long-standing hemorrhages can give rise to gallstones, same like hereditary spherocytosis. So here the problems with iron overload is very important in these cases. Iron overload which occur before or as a consequence, it can occur before or as a consequence of transfusion, is a particular problem in children with thalassemia. What are the iron overload problems here? Endocrine problems. This becomes commoner after multiple transfusions. Growth can be impaired, puberty delayed. As we know, any chronic condition will cause growth impairment. We should remember. So there will be short stature showing the faltering in growth. So growth impaired, delayed puberty, hypothyroidism and hypoparathyroidism can occur. Diabetes mellitus can occur due to pancreatic cirrhosis. All this problem is due to iron deposition. So the iron deposition in the thyroid and parathyroid can cause hypothyroidism and hypoparathyroidism, and in the pancreas can cause diabetes mellitus. They have delayed puberty, growth impaired, and also deposition in liver can cause cirrhosis. Cardiac failure can occur due to cardiac cirrhosis. So all these things is due to iron deposition. So we have to remember head to toe, like first, so thyroid and parathyroid, there will be deposition in the thyroid and parathyroid. Iron deposition will cause hypothyroidism and hypoparathyroidism. Okay, then coming down, you have here liver and pancreas. So iron deposition in the liver can cause cirrhosis, and in the pancreas can lead to diabetes mellitus. Okay. Then even in the heart, there can be iron deposition in the heart, and this might lead to heart failure. This is called cardiac cirrhosis. Okay. With modern technique and management, With modern technique and management, many of these complications can be avoided and others ameliorated, their onset delayed. So very important things. When you're taking history of thalassemia, you have to ask for symptoms of hypothyroidism. Okay, and also you will ask for these questions related to checking their glucose, anything raised or anything, and even cardiac symptoms like any edema, any difficulty in breathing, all those things. You have to keep in mind these questions which are caused due to iron toxicity or iron overload. So iron overload, main endocrine problems here is the thyroid and parathyroid, and they can cause growth impairment and delayed puberty. So 4 things here: growth impairment, delayed puberty, hypothyroidism, and hypoparathyroidism, and also diabetes mellitus. 5 things. Then in the liver, it can cause cirrhosis, and here in the heart, cardiac failure. So what is the treatment? How do you treat? Aims to control the ineffective erythropoiesis and so reduce the likelihood of hypersplenism. So you have to control this ineffective erythropoiesis and reduce hypersplenism and its complications. Next is the this we can go and check UK Thalassemia Society. If you check, especially only for the treatment and management, the recent things will be uploaded, just like how we checked in patient info just now before this. Hypertransfusion regime, blood transfusion on regular basis, example monthly, to maintain. So you should know your target. Your target hemoglobin should be about 10 grams per deciliter. This is target. Keep your target as 10. So once in a month, at least once in a month, regular basis blood transfusions are given to keep hemoglobin about 10 grams per deciliter. Decision to start is based on regular assessment of clinical problems, particularly emerging features, bone and cardiac involvement and growth. So if you want to put them on hypertransfusion regime, that is maintaining the hemoglobin 10 grams on and monthly transfusions, you will take the decision to start based on regular assessment of clinical problems, that is emerging features of bone and cardiac involvement. Any bone involvement, like there is frontal bossing, malar hyperplasia, there are problems with iron overload, and also growth, stunted growth, delayed puberty. Iatrogenic iron overload is a consequence of frequent transfusions and needs to be anticipated and prevented with chelation. So before the problem happens and there are side effects like hypothyroidism, hypoparathyroidism, whenever you give transfusion, since you know that there will be iron overload, you have to give chelation. So chelation therapy should commence when ferritin has reached. So the laboratory results here, if ferritin is more than 1000 milligram per liter, usually around 10th to 12th transfusion. So you should start chelation therapy when the ferritin reaches more than 1000 mg per liter. Okay. Usually around 10 to 12th transfusion. Desferoxamine is most commonly used agent and it is given by subcutaneous infusion. So how you give desferoxamine? Subcutaneous infusion, 8 to 12 hours period, 5 to 6 nights per week. The injection sites give rise to depigmented patches on dark skin that are seen in most patients. Ask about compliance in adolescents. Side effects include visual problems, sensory neural deafness. So vision and hearing should be tested before therapy and regularly thereafter. So when you give at least 10 to 12 transfusions, when the ferritin increases more than 1000 mg per liter, you will give this subcutaneous infusion 8 to 12 hours for 5 to 6 nights. So compliance will be difficult in adolescents. There will be depigmented patches. The side effects is the visual and sensory neural hearing loss. So vision and hearing, you have to remember both vision and hearing should be tested before starting and also after starting to be sure that this is not from before and any hearing loss happened after therapy. Then folic acid supplementation often required as increased erythropoiesis uses up folic acid. So in all the three, sickle cell, hereditary spherocytosis, and thalassemia, you will tell folic acid supplementation. Then splenectomy. Splenectomy may be necessary in some patients with severe symptoms of hypersplenism. This will often reduce transfusion requirement, but there is high risk of bacterial sepsis. So again, hypersplenism, we should know the indications of splenectomy. I have written my notes. I will tell you after this. Allogenic bone marrow transplantation. So this is the treatment now. Is considered to be curative. So if they ask you, is there the permanent solution for this? Yes, there is permanent solution. That is allogenic bone marrow transplantation and is being used with increasing success. However, it carries significant morbidity and risk of mortality. So patients need to be carefully selected. This is being done now with increasing success according to them, but still you have to be careful in patient selection and there can be morbidity, mortality, and rejection as well. Remember the importance of multidisciplinary team approach here. Hematologist, cardiologist, psychologist, genetics team with genetic counseling for the family. Very important in all these three conditions. Genetic team with genetic counseling, hematologist, cardiologist, psychologist, and specialist nurse. Okay, so I will read out the indications of splenectomy in this, in thalassemia case. Just 1 minute. So indications for splenectomy in thalassemia, you have to remember 4 points. Sorry, 3 points. One is hypersplenism or too much large spleen, okay, which is causing difficulty for the child, and increased blood transfusion requirement. They require more blood transfusion. That is more than 240 ml per kg per year. Okay. This is in my notes. Maybe I have written from somewhere. You can go back and check. So one is the hypersplenism or too much large spleen causing trouble to the baby, means the spleen is too much large in the tummy. The baby has difficulty in respiration or movements like this. And their blood transfusion requirement is so high that they require at least more than 240 ml per kg per year. Okay. And I have some more points I will read out for you. So desferoxamine, we were reading the side effects, visual problems and sensory neural deafness. And also some oral chelators, they may have side effects like neutropenia and arthropathy as well. Okay.
Tutorial note, there is one sheet for Dr. Abraham. He wrote also for splenectomy. If the patient aged more than 5 years, requirement increasing from 180 to 250 ml per kg per year, packed red blood cells, huge spleen causing discomfort or increased risk of traumatic rupture.
Yeah, means, yeah, as I told you, yeah, the spleen is too large that it will cause discomfort for the child. And also there can be chance of traumatic rupture, right, in the large spleen. And he told this 180 to 240 ml. And features of hypersplenism. So hypersplenism is a clinical syndrome in which normal splenic function becomes excessive as spleen and its mononuclear phagocytic tissue enlarge. As the spleen enlarges, the normal splenic function becomes excessive. This will result in pancytopenia. So this is called as hypersplenism. It will not just affect RBCs, it can start affecting the other cell lines also. Pancytopenia can happen, like thrombocytopenia, neutropenia, along with the anemia. So hypersplenism is a clinical syndrome in which normal splenic function becomes excessive as the spleen and its mononuclear phagocyte tissue enlarge, and pancytopenia usually occurs. The most common cause is venous obstruction, such as seen in extrahepatic venous obstruction. So this is a venous obstruction, what we see even in the portal vein thrombosis. But what happens here in thalassemia is there will be huge large spleen because of the extramedullary hematopoiesis. And this large spleen will start causing hypersplenism. So if if it is causing hypersplenism and going to pancytopenia, this is one of the indication. Then too much large spleen causing difficulty for the child is another, and requiring blood transfusion more than 180 to 250 ml per kg per year. This you have to remember, okay? Then hyposplenism refers to diminished splenic function associated with either absence of spleen, it is congenital, or following splenectomy. Anytime you removed spleen or it is congenitally absent spleen, then it is hyposplenism, or functional impairment, functional asplenia. We call it as functional asplenia in sickle cell disease. The main consequence of hyposplenism is risk of overwhelming bacterial septicemia. So prophylactic penicillin and pneumococcal and meningococcal, and also add here HIB, pneumococcal, meningococcal, and HIB immunizations are required. So always any case like this comes for history, immunization history is very important, and any prophylactic medications they are taking. Usually these children will have folic acid and and sickle cell, all children, sickle cell anemia will have penicillin V because they will have functional asplenia. But if these children have undergone splenectomy, then again you have to take history of taking penicillin and all those things. Okay. And there is one more important point I want to tell, anyone can tell about what else infections can be common in these patients due to the use of desferoxamine.
Gram-negative sepsis is common.
There is a particular organism which will cause
Yersinia enterocolitica.
Yeah, in Yersinia infection. So sometimes what they do, the Yersinia, and most commonly it will cause appendicitis in these patients. So sometimes they also prefer to remove appendix when they are planning for splenectomy. Okay, this is also there. Just go back and read about it. Okay. So, okay, we did 2 cases today. Next time, maybe we can practice thalassemia and also one more sickle cell anemia. If we do this 2, the hemolytic anemias, we will be doing inshallah. We will be finishing inshallah. Okay, if anyone has any comments or any additional points, can go ahead before we end the meeting.
There is any source to read iron chelating and the complication?
I think here he has given no in mark. Actually, I did not go through it. That's why I did not share it. Maybe if I go through, we can do it in the next meeting. In mark, he gave that no, before starting treatment, he told guidelines on the management of thalassemia can be found in website UK Thalassemia Society. Just go through this, because they would have given some updated treatment and management which is going on at present. Okay, whatever we read from Mark, I want to go through it. I did not go through, so just I did not share anything about it. Okay, it is www.ukts.org.
Okay, thank you.
So thank you all for attending. I will end the meeting.